Welcome to this discussion on some of the frontiers in cervical cancer prevention nowadays. This is my conflict of interest declaration. And let me start by reminding that HPV-induced cancers represent a significant health problem in the world. We estimate that about 630,000 cases per year, of which 55,000 are in men. And clearly the tumors that have been associated are the oropharyngeal cancers in both men and women, the genital tract of the female in the cervix, most of them, but also in the vulva and the vagina. And for the males and the females, the anal canal, and for the males, the cancer of the penis. In Europe, even after so many years of screening for cervical cancer, we still account for some 80,000 HPV-induced cancers, of which close to 10,000 are in males. So this is the problem that we have, and this is the way we can handle it in the future. So perhaps one of the most important decisions made by the World Health Organization in relation to the HPV was the definition that cervical cancer could be eliminated as a public health problem, and that could be done within the century. This is a pretty arbitrary definition because it only refers to the expected incidence that we will call elimination as a public health problem. And in this case, the attempt is to reduce globally the incidence to 4 cases per 100,000 women per year. And the strategy that WHO gave us was focused on cervical cancer, not so much on the other HPV-induced cancers, with the idea that we could achieve by 2030 a 30% reduction in mortality. And the pillars of that strategy includes HPV vaccination, and they call for a certain threshold so that 90% of girls before the age of 15 receive an appropriate dose of HPV vaccines, that 70% of women, non-vaccinated women, would be screened with an HPV test at the ages of 35 and 45, and that 90% of the screen positives and the cervical cancer cases will have access to appropriate treatment. Now, setting a goal of 90% participation in a vaccination program or 70% in the screening program, it certainly requires a very strong social commitment and engagement, a generalized participation of the population. It requires attention to all minorities and risk groups. And this has proven to be one of the frontiers for the HPV field, which indeed now have to face issues like vaccine hesitancy, anti-vaccine movements, reluctant to participate in screening programs, gaining the ability to follow up and treat the cases that are identified at screening, and so on and so forth. So that could be a frontier that would require a full session just to discuss how to do communication. But there are other frontiers that reflect different aspects of the interventions that could be improved. To improve the value of vaccination, we are now discussing male vaccination, expand the indications to vaccinate other age groups and high-risk groups, the issues of identifying if 2 doses or 1 dose is indeed sufficient to ensure lifetime protection against the infection and the disease, and the ability to generate cheaper vaccines, newer vaccines. These are all areas of research that could be considered frontiers. For the screening component of the strategy, self-sampling and HPV testing and triage is probably one of the most significant advances over what we had with the Papa Nicolau smear. Self-sampling allows women to take the specimen without requiring a medical visit. And then technology needs to be calibrated to be able to test for HPV and to triage the HPV positives into risk groups and management groups. More recently, the use of urine tests to test for HPV or for other biomarkers is emerging as an area of considerable interest. And in the treatment component, certainly there is a major limitation in many countries in what refers to the availability of colposcopy clinics and trained personnel, as well as in the oncology field, the manpower and the equipment required for an adequate oncology treatment. Whenever you see a slide like this one, just remember that you are invited to submit questions that will be addressed at the end of the session. So in terms of HPV vaccines, the two main parameters that drive our evaluation and monitoring is first of all, the efficacy of the vaccine, and the second of all, the coverage of the target population. And in terms of efficacy and in terms of safety, the results for these vaccines are extraordinarily satisfactory. So under a natural history that relates the exposure to the virus, the preneoplastic lesions, and the progression to cancer, trials and public programs have already shown convincingly and consistently that there is a very strong protection against infection, against persistent infection, against all the preneoplastic lesions in the cervix, in the vulva, the vagina, the anal canal, as well as for genital warts. Evidence also start to emerge that respiratory papillomatosis from mothers that are infected with HPV 6 or 11 are also dramatically reduced when the population is vaccinated at large. But in the last 2 or 3 years, we got the final proof of causality and the final proof of efficacy, which is showing in population programs that vaccination of adolescents reduces very rapidly, more rapidly than we anticipated, the incidence of cervical cancer. And some evidence start to emerge that it also is the case for other anogenital cancers and eventually for oropharyngeal cancer. That we will have to wait a little bit. But also these 20 years of vaccine research have also shown that the vaccines are extraordinarily safe. There are no serious adverse events in over 250 million persons vaccinated, nor on any special risk groups that have been investigated, such as HPV positive women, HIV positive women, pregnant women, lactating mothers or individuals with immunodeficiencies. There's always this concern about safety that has been successfully cleared by the WHO review committees on that matter. And let's see what are the two reports that have documented the protection against cervical cancer. This is a study in Sweden. They were using the 4-valent vaccine. They included 1.7 million girls that were 10 to 30 from 2006, where the vaccine was introduced, to 2017. And they calculated the risk of cervical cancer by vaccination status, comparing with pre-vaccination times. And you have here in yellow the incidence of cervical cancer in unvaccinated women and the incidence of cervical cancer in women vaccinated before the age of 17. And women vaccinated between the ages of 17 and 30 are somewhere in the middle, waiting for that difference to become statistically significant. But when you look at here, the vaccinated before 17, the protection against cervical cancer is in the 88–90% of the cases, an extraordinary result obtained 15 years after the introduction of the vaccine. So very fast and very dramatic. The other observation using the 4-valent vaccine is the potential for herd protection in the community. Here you have a meta-analysis including 60 million girls that received the quadrivalent vaccine at the ages of 15 to 24. And this is the relative risk for genital warts up to 5 years after vaccination. So the first conclusion of this graph here, there's an extraordinary paper by Rollet et al., is the value of intensity of vaccination. So the blue lines here, they represent countries, they have a multi-cohort vaccination and or a high vaccination coverage, greater than 50%, in programs that only vaccinated girls. And you see that 5 years after vaccination, the incidence of genital warts dropped dramatically close to 0. In countries where the vaccination is less intense, for example, they used a single cohort vaccination or low vaccination coverage, less than 50%, you see that also you observe that reduction, but it's not exactly the same as the impact when the intensity of the vaccination is high. So first conclusion, vaccination intensity is a determinant, a parameter of extreme value for monitoring. But the other observation of this meta-analysis is the impact in boys that were not vaccinated. Therefore, this is the impact in males of vaccinating only the girls in the community. And you see that the scenario is about the same. For the high vaccination populations, there is a dramatic drop in genital warts, almost as intense as in females, showing that if you achieve a high coverage of the women, you will also have a high impact in the male population. If your vaccination program is of low quality, you see that there is no impact in the herd protection effect. This is probably the first and unique, if you allow the exception of the hepatitis B, this is an infection that leads to cancer and is sexually transmitted. So the patterns of sexual behavior in these communities, they do reflect that impact, and they do anticipate why is it important to vaccinate men and women, and why it is important to achieve high coverage. The second study that reported on the protection against cervical cancer was in the UK. They reported on efficacy against cervical cancer and efficacy against CIN3. They used the bivalent vaccine, and they included 13.7 million woman years. Again, the cohort 0 is the reference, is the cohorts before the vaccination program, and the cohort 1, 2, and 3, cohort 3 here represents the incidence of cervical cancer in girls that received vaccination in the age groups 12 to 13, the very young ones, and 85% coverage of that population was achieved. So for this group, the protection against cervical cancer was 87%, almost identical to the one that we just saw. But the protection against CIN3 was 97%. And this is a very strong determinant of what will happen with screening. It means that the cohorts that are vaccinated very early in life and they achieve a high coverage here, they are free of the disease. And if they are free of the disease, the impact of screening and the nature of that screening, as well as the frequency of that screening, needs to be dramatically modified. So with such an extraordinary vaccine, how far have we gone so far? Well, these are the estimates that are produced by the ICO, Dr. Laia Bruni, and her colleagues at the World Health Organization. These are official data from the OMS. And they reported that the countries that introduced the vaccine are mostly developed countries so far. In 2019, there were 116 countries that already introduced the vaccine. The latest report is 157. So over 50% of the world has introduced HPV vaccines. And the coverage achieved for all the introducers, 68% for the first dose, 54% for the final dose in programs that were still requiring 2 or 3 doses of vaccination. If indeed one dose ends up to be the formal indication because it is sufficient, then we are now at the level of 70% coverage of the countries that have introduced the vaccine. It is of great interest to observe that for the wealthy countries in the world, first dose coverage is 66%, low and middle income countries is 69%, very nearby. So once the country decides to introduce, they do a very good job both in the wealthy and the not so wealthy countries in the world. These are data for Spain, for example, as a reference of individual countries that are vaccinating very well. But then if you put that into perspective, you realize that gigantic countries like China or India or Nigeria, they have not introduced vaccination. And the majority of the population and the cases are in countries like these ones. So globally, the coverage of public programs for women is 15% and 4% of males. So there's a huge work to do to make sure that these vaccines arrive to the countries that have the strongest population and they have very high rates of disease. Again, questions are invited. And we move into the screening and management of HPV infections and HPV lesions. And we call that the long road from pap smears to cell sampling and HPV testing, because indeed it has been a long road. And this graph, again, from the group of Laia Bruni and the ICO team, says it all in one slide. Here you have the population of the world broken down by high-income countries, upper middle, lower middle, and low-income countries. And the green bars here represent women that report cervical examination in the last 5 years, screening event in the last 5 years. The yellows are the ones that report at least once in their lifetime, and the reds are the never screen. And clearly, for low and middle income countries, even for the upper middle income countries, screening has not really worked in the 50 or 60 years since Papa Nicolau. It is a preventive strategy that has worked in high socioeconomic populations. So globally, 2 out of 3 women 30 to 49 have never benefited from any screening test. And for the ones that are ahead of everyone else, the transition from the pap smear to HPV is much slower than anticipated, surprisingly much slower. So 68% of the countries have formal guidelines, and of those guidelines, HPV screening was reported in 48 countries, which is 35% of the ones with guidelines, and 25% of all countries. So still the majority of countries, they recommend cytology, or they are still exploring combined formulas. In here, the solid colors like the Australian one means that they recommend HPV testing alone. Many of the European countries are already going into that direction. And the stripe pattern, which is here, the majority of the Americas, majority of European countries, it represents that they allow for 2 different options, either as a combination, and this is called co-test, means every screening event has a cytology and an HPV testing, or with different indications, for example, using cytology first and HPV as triage, or the other way around. And then the majority of the low-income countries, they are still without an official recommendation and without introduction of HPV testing. Again, a major determinant of how to use and how to apply the recommendations of the World Health Organization. And here's the way I present the problem of frontiers in research for cervical cancer prevention. So public health, HPV vaccination, HPV screening, and cancer treatment. In here, this has been for a long time an area of public health, pediatricians, and general practitioners. The world of screening has been led by the pathologists, gynecologists, and colposcopists. And the field of treatment, it is the domain of the oncology, surgery, and radiotherapy. And how can we combine these 2 scenarios? First of all, how do we screen vaccinated cohorts? We've seen that vaccinated cohorts in Europe, they show a reduction of HPV infections, very high, CIN2, CIN3, or cervical cancer, extremely high reductions. Under these circumstances, and in populations where the disease is already relatively rare, cervical cancer, cervical precancer, will no longer be a public health problem in itself. And continuing screening will increase the risk of false positive and overtreatments. So in those populations, clearly there's a need to reduce the screening events and simplify the screening protocol. That seems to be clear, although very few countries, they do have a specific algorithm for screening vaccinated cohorts. And what I'm keen to present today to this discussion is the other way around, is how vaccination can support and complement the cohorts that are being screened. And this reflects the idea that since the introduction of the vaccine in 2006, we've been continuously expanding the indications. Remember that we started with girls before sexual initiation, 1 cohort, 3 doses, very complicated preventive scenario. Since then, we moved into recommending vaccination of multiple cohorts, gender-neutral vaccination, adult women vaccination, and targeted campaigns for a number of high-risk groups that have been identified for transmission and progression. So that in itself indicates that perhaps we could do more in every screening event if we combine it with an indication for vaccination. We certainly have to deal with the annual visit that is embedded in many practices in many European countries and wealthy countries in the world. And then if cervical cancer is losing its presence in the protocols for the annual visits, we have to start exploring novel oncologic biomarkers for endometrial and ovarian cancer, other cancer screening, and other health problems that are very prevalent in our communities of women nowadays. What is the rationale for doing that, for expanding vaccine recommendations, particularly in women in middle age? Well, the 2 criteria that are determinant here is that the HPV reservoir is only human. There's no other environment in nature where the virus can replicate, which is one of the problems that we have with other viruses. So human intervention will deal with all the resources, all the sources of infection and transmission. And the other one is that screening, particularly when HPV testing is introduced, identifies the positive women routinely. And these positive women are the center of attention. So in the conventional screening scenario, the objective is to protect the HPV positive women from progression to CIN3. We are just dealing with the individual itself. And how do we do that? Well, we increase the number of visits, we repeat visits, we do triage, do the biomarkers, eventually biopsies, colposcopies, and surgery. So we focus on the women. But now we recognize that these women are also the transmitters in the community. And while we are doing all of that, before and after, that woman is a transmitter in the community. And how can we handle that? Well, first thing is universal HPV vaccination. This is the way we are moving towards. Gender-neutral vaccination has been adopted by at least 50 countries in the world. Most countries are vaccinating girls and are considering vaccinating males as well. And the second component is that as soon as we identify an HPV positive individual, in addition of caring for that individual, we are trying to interrupt transmission by vaccination. And the group that is the transmitter in the community has been estimated several times. For women, on average, is 12% positivity rate. In some populations, it's 2%. In some populations, it's 30%. And for males, we don't have that much information, but at least 25% are positive in any given moment. So the question is, if we vaccinate these individuals, will be boosting the protection that we have seen the herd protection effect offers. And that is the concept that we are now considering, which is the fact that HPV vaccination can be understood as a biological condom. We know that as we vaccinate individuals, the antibodies, they transudate and they exudate to the cervicovaginal fluid, particularly if there is a lesion. These antibodies, they attach to the surface of the virus and they prevent infection and everything else afterwards. So we have proven that very efficiently for infection, that's viral entry, and we are now investigating if that operates in the same way when a positive woman with a CIN2 somewhere is shedding virus. If the virus, they go through the same antibody loaded cervicovaginal fluid, the virus goes out already coated with antibodies, thus reducing the risk of infection of the males. So reducing infections has been proven, may reduce transmission is the hypothesis that we are investigating nowadays. And HPV faster is one of the models that we usually promote at this stage. Over a scale of age, screening typically starts around the age of 23, 25, perhaps a little bit more in some countries, and it goes on forward. And the indications for vaccination, it depends on the geographical areas. For example, in the United States, because the trials end up at the age of 45, the upper limit of indications is 45. In Europe, with exactly the same review of the literature, they do not put an upper limit for vaccination. They say if the vaccine works at the age of 45, it will certainly work at the age of 50. And then the indication is left to the countries to decide. So in that context, HPV vaccination from before the age of 15 is the absolute top priority. And we realize that this will generate a time lag before having achieved massive vaccination to seeing the impact in cervical cancer. In many countries, vaccination has also included groups up to the age of 26, 27. That's the catch-up vaccination trials or vaccination studies. And they already moved from 2 doses here to 3 doses here. But then the faster calls for saying, okay, if the vaccine works and if the vaccine has the promise to reduce transmission, how about vaccinating anyone up to the age of 45, irrespective of their screening results? This is very important. So we vaccinate these women because we know that the vaccine is efficacious and the vaccine is safety, at least up to the age of 45. But we know that in these age groups, some infections, many infections have already occurred in the younger age groups, and therefore we have to deal with these women who are at high risk for cervical cancer. So this vaccination event needs to be parallel to an HPV screening test. So that's the new concept of a strategy that addresses the ages 25 to 45. Now, if we do that, and then the HPV test turns out to be negative, we have women that are HPV negative, no risk, short-term risk, receive a polyvalent vaccine, therefore very strong protection forward. So the need of continuing screening programs is dramatically reduced as a simplification of the follow-up. In some instances, depending on the results, when this hypothesis is being tested, we might end up by ending the program at this stage here. If the woman is HPV positive, that would represent perhaps 20 to 30% of the population. then these women, they need to be followed up and treated because they are at high risk already. But at the same time, that vaccination episode mitigates new infections because typically a person is infected with 1 or 2 types, but the vaccines, they cover more types. Person becomes protected against new infections, but it also reduces potentially the transmission in the community. If the 1-dose proposal completes its investigation phase relatively soon, we expect that in a couple of years, then the simplification of the entire scheme will be more relevant, and therefore the program itself would be more feasible in many developing countries. In fact, one of the more advanced tests of that hypothesis is being now conducted in Sweden. They use the R0 in non-vaccinated women to define the threshold of age vaccination. Remember that if your RO is in the 1 in the reference point, then the pandemic or the infection will continue stabilizing the population. If it goes up from 1 to 2, it indicates that there's an active transmission and infection, very high transmission rates. If it goes below 1, then the risk of transmission becomes stable and finally goes down, and clearly reflecting the sexual behavior in relation to age. So the entire population then gets stratified into 3 levels of risk. For the very young, there is very high transmission rate, but they are intensively vaccinated, and therefore vaccination will take care of that component here. For the women up to the age of 32, 35 in Sweden, the R0 goes below 1, therefore there is an infection that is led to be extinct by itself. And the brown ones represent the women that still transmit and have not been vaccinated. And for this group here, then the offer of HPV screening and vaccination makes all sense in the world. Indeed, it also was reinforced, that concept, by the COVID epidemic, in which Sweden showed that vaccinating the entire population of Sweden was feasible within weeks, and therefore a component like this in a relatively small population is something that is very feasible. So I would like to close by saying that these analyses have been intensively modeled, and you will find results all over the place. This is one example, which is a meta-analysis of a very large number of programs and the predictions over 100 years from now on the incidence of cervical cancer. So if we keep screening and vaccination, or even twice HPV screen as it is nowadays, at the end of the century, the cervical cancer incidence would be increased to the level that we are observing today. And then if we vaccinate, you have here the various alternatives. This is the vaccination achieving very high coverage, 80 to 100% with a 4-valent vaccine. The bivalent vaccine, including cross protection. The 9-valent vaccine is the burgundy color here. The G9, the 9-valent vaccine plus 2 HPV screening events, they even move the graphs more to the left. And a dramatic version of the FASTER program, which is in here, a 9-valent vaccine and vaccination up to the age of 49. It accelerates the reduction to any threshold that one would like to define by perhaps 20 to 30 to 40 years. So the tools are there and we know how to use them. So the new paradigm that we are creating now, imagine for the age groups that are female age groups, if we now have here the years in which Papa Nicolau described his test, the first medical indication was to repeat cytology every year. So the number of screening events was extremely high. Then it was slowly moving to every 3 years or every 5 years, depending on the quality of the program. When the vaccines arrived, vaccination became the primary strategy for the very young and for the not so very young women. And then because of the impact of vaccination, the screening component was reduced to HPV tests. Cytology is not indicated in the circumstances every 5 to 10 years, so a significant reduction in the number of screening events. And what we are promoting now is the idea that we might even increase the vaccination scheme, perhaps up to the age of 45. And these individuals will have to have certainly one HPV screening test at around the ages of 25 to 45 to screen out the HPV positive ones. But after that, then perhaps the number of required additional screening events will be reduced to perhaps 1 or 2, or even perhaps none. And clearly the male vaccination will, or is already adding quite a lot to this program. So as a summary and to conclude, clearly we have to address the issue of low and middle income countries. We've seen that with the vaccination programs. We've seen that with the screening programs as a matter of international equity. And the most important decision is how to better combine vaccination and screening. In the side of vaccination, we need more and better vaccines, and that refers to, for example, polyvalent vaccines, including other antigens, one dose, low cost, avoid injections in the administration of the vaccine. All of that can be articulated and will certainly be an object of research in the coming years. For screening and triage, we certainly need technology for low and middle income countries, because the scheme that we are using in Europe is clearly not sufficient for these countries. And urine samples, self-samples, simple testing methods. Remember what we achieved with COVID, that everyone was able to test him or herself at home. And then for treatment of HPV and cancer, these have to be calibrated to low and middle income countries, and oncology research for developing countries is of paramount importance. With that, I thank you very much for your interest, and recognizing that since Jenner did the first vaccines against smallpox, there's still much work to be done. Thank you very much.
Well, thank you, Xavier, for your session. It was a pleasure for me to be here tonight. Good morning, good afternoon, and good evening, everybody. We have, of course, a lot of questions about the session you have just finished. I just read something for you. The first is about WHO cervical eradication campaign, which represents a feasible target. Yes, challenging but feasible. Do you think we can achieve this goal with the current commercially available vaccine, or better? In other words, the globally supply, it's enough. We need some new vaccines, something like injectable or oral vaccines, or we need something about therapeutical vaccines. Please comment on this.
Well, these are a number of questions. Clearly, what WHO did was to indicate tools that will get rid of cervical cancer. So, and each one of these tools can be improved. We have excellent vaccines, but we certainly have cheaper vaccines, more easily to administer vaccines, heat-stable vaccines, vaccination campaigns properly organized in the majority of the countries. So I think that the value of the WHO declaration is to point to the world that here is a series of cancers that are induced by a virus, that we know the virus, and we have achieved screening and vaccination tools. And then what is important to to understand now is that countries, individual countries, they need to come together and calibrate that strategy to their reality. And it will not be the same in Sweden, where they have small population, very organized, with high coverage of vaccination and high coverage of screening, as if you go to China, where you have a gigantic population with less developed infrastructure for vaccination and screening. But the countries need to do that effort, and the objective has been set. It is inspirational. You don't have to take it literally, but this is the way that we can advance in the transition to that. You might realize that there are many countries that are very close already to the 4 per 100,000, and one of the first objectives of this calibration process is to actually define what incidence would be acceptable for a given country. In Australia, for example, instead of 4 per 100,000, decided to go to 1 per 100,000 as their threshold for elimination.
Okay, another burning question is about single dose recommendation. Well, we know that has the potential to take us faster to our goal of having 90% of girls vaccinated by the age of 15 by 2030. We have seen the global coverage is very low, and we noticed that Australia and the UK moved from 2 doses to a single dose. Do you think we have enough data to do so globally or not?
Well, the indirect evidence is very strong, and there are 4 major trials ongoing, which are already generating results and will be completed in a year or so, that are properly randomized control trials looking at the value of 1 dose. For the time being, all the information that is coming seems to indicate that 1 dose would be sufficient, or at least would be equally effective than 2 doses and 3 doses, at least for a short follow-up time. In coming years, we'll see if that needs to be changed, but my understanding of the evidence is that indeed 1 dose will be sufficient, and that will simplify enormously our capacity to reach the most difficult populations.
Okay. There's, well, something about safety, need no comments with 250,000 million person vaccinated. So efficacy is even better. And looking at the impact about anogenital words and vacciner effect, we have seen some models thinking about gender-neutral vaccination, talking about how a coverage of 75% in both sexes could be enough for a strong impact on viral prevalence. Can you make a comment on this? Because WHO don't talk about male counterparts, so just a few words.
Yes, WHO doesn't discuss male vaccination. It's very much focused on cervical cancer. And cervical cancer is a female cancer, and therefore the strategy is conceived for females only. Now, since that declaration was made, the evidence for male vaccination is increasing. And certainly there are now models that predict the elimination of certain HPV types, and they have shown that HPV 16 is the most difficult to eliminate and requires a higher coverage. But they also observe that if the vaccination occurs in females and males, this HPV 16 elimination can be achieved with a relatively lower coverage. That has been modeled in the Finland and other Nordic countries studies, and seems pretty consistent information. Vaccinating males, it also ensures that if anything occurs in the process, such as the COVID pandemic that interrupted vaccination programs in the majority of the countries in the world, if there is a shortage of vaccine or there's an interruption of the vaccination program, the global effect is more resistant if males and females are vaccinated than if only females have been vaccinated. So nowadays, it's about 50 of the more developed countries in the world that have adopted male vaccination as well as a routine practice.
Okay, another question coming from the floor is that if you know, in your knowledge, there are some RCT ongoing looking at the efficacy and the safety in infants' age. In other words, do you think it's better to get immunization before the age of 9 years old? A comment on this, please.
Well, there are few studies looking at the immune response in infants, but certainly one of the areas of interest for the future is to see if the HPV vaccine could be included in the EPI vaccination scheme. Because some of the problems that we have encountered when we proposed vaccination of adolescents and vaccination of adolescent girls only was the reluctancy by the population to understand why boys were not vaccinated, why only girls, and the difficulties that were created by the discussion that this is largely a sexually transmitted infection. And then in some countries, parents were unwilling to accept that their infants or their girls would be sexually active relatively soon. And they didn't want to talk about that. So looking at the infancy also was a relatively low priority for a number of years, because we know that the infections occur after sexual initiation. So in the hypothesis that the vaccine had a short-term protection timeline, imagine that this vaccine that works very well for 10 years, you want to spend these 10 years in the years of the maximum risk of infection, which is, let's say, 9 to 19, right? So if you vaccinate 1-year-old with this vaccine or 3-year-old with this vaccine, many of the efficacy years would be spent before there is much risk globally to get infected. Now we know that these vaccines are very long lasting. So this is yet another piece of information that supports the concept that this vaccine might in the future be integrated with other vaccines and administered at infancy as part of the routine vaccination scheme, without the discussions on sexual behavior and age at sexual initiation and stigma of the infection and so on and so forth. That has been a constant circumstance in the introduction of this vaccine in the past.
Okay, I give a look and I think we have just finished with the questions. I just want to make a personal comment, if it's possible. Just say that we are living in a revolutionary era, I would say. Communication makes the world so small. Like this evening, we can share ideas like Professor Bosch did, and other ideas sure will come. The viral education campaign is now a reality, and this session provided some strategies. But now it's time for the commitment. Every one of us, pediatrician, gynecologist, midwife, everyone play a role in this project. It is our direct responsibility to provide the tools to understand the importance of vaccination, prevention, treatment. So I would say that every year we fail in our goal we must face year of preventable cancers. So get in mind that is our direct responsibility. That's all, Xavier.
Thank you very much, Alessandro. Thank you for your support of the session today. And I think that it's the last message from the European School of Oncology in the screen.
Good evening. Good night, everybody.